Good, good to see you. Come on, really. Yeah, so we're trying to do it twice. Yeah, no one's.
Welcome, everyone. Welcome. We'll go ahead and get started. It's so wonderful to see you all here. My name is Tom Hale. I'm a professor here at the Blavatnik School, and I'm the academic lead for the Oxford COVID-19 Government Response Tracker, which is what brings us here today. This event is co-sponsored by the Blavatnik School and the Pandemic Sciences Institute here at Oxford. And our objective is to do two things: to look back at what this project, the Oxford COVID-19 Government Response Tracker, has learned about the world, and most importantly, to celebrate the people who have made that project possible, who are the 1,500 plus volunteers who have given up time over the last 3 years to contribute data to this global platform, as well as everyone else who's contributed through work, as partnerships, et cetera. And so it's an exciting opportunity to see old friends, to see new friends, and to look back and celebrate service. Just a word about what the project has done. So it began actually right here in this very room. This is the main lecture theater for the Blavatnik School. And in our Masters of Public Policy course in 2020, we were talking about what different governments were doing. We were seeing these crazy things happening around the world, things we hadn't seen before. And we had more than 70 different groups, nationalities in that cohort who were able to compare what was happening in their country to other countries. And from that discussion emerged a need and a desire and a vision for a more systematic effort to track that information. And 3 years later, it's become a massive global public resource that's providing one essential piece of the data ecosystem the world needs to manage COVID-19. So our agenda today is to think about exactly what we've learned from that process, but also, as I said, to celebrate the achievements and the service that's gone into building it up. We're going to start off with a few welcoming remarks. Then we're going to have a fascinating panel where we're going to hear from some decision makers in different governments around the world who have actually been the people deciding on the responses that this project has tracked. So we're going to hear it from the front line, if you will. And we're going to close with a few reflections on the way forward from here. Because even though we're at a moment in time, almost 1 year from the anniversary of the first lockdown here in the UK, where the world is kind of looking beyond this phase of the pandemic, we know this is not an issue that's going to be gone this year or in future years, but rather is something we need to adapt to as a world. And that's why the project is really thinking about its next phase. Let me turn to our first set of opening and welcoming remarks from someone who I'm delighted we're able to host virtually here in the school. Dr. Tedros is the Director General of the World Health Organization, and a clinical doctor and a researcher. He began his career as a malaria researcher, became the health minister and the foreign minister of his country of Ethiopia, and was elected as Director General of the World Health Organization in 2017 and 2022, and has kindly provided some welcome remarks for all of our volunteers today.
Dean Woods, Professor Horby,
and just some audio.
Dear colleagues and friends. On behalf of WHO, I thank you for your tremendous work over the last 3 years. The scope of this network, over 1,000 volunteers in more than 100 countries, is truly impressive. It filled a critical gap during a global crisis. Your work shows what can be achieved when people are united by a common purpose. The lesson of COVID-19 is clear. Shared threats require a shared response. Thankfully, the pandemic now appears to be receding. But this will not be our last pandemic or our last global emergency. The global cooperation and coordination you have been a part of is a model for emergency response efforts in the future. Your work will inform WHO's efforts to track the various governments' actions and to monitor their implementation and adherence. WHO is also developing customizable guidance for setting up a tracking system for emergencies of different kinds. When crises strike, good data is critical both for guiding equitable, evidence-driven, and community-centered public health policies and for minimizing their negative impacts. Thank you once again for your work in helping to build the evidence to keep future generations safer. I thank you.
Thank you, Dr. Tedros. And for a second set of welcome remarks, I'm happy to turn to a leader closer to home. Professor Irene Tracy is Vice Chancellor of the University of Oxford. She's a professor of anesthetic neuroscience and the former warden of Merton College, and is a world expert on the science of pain. She has also been appointed by the government to the Council of Medical Research, the Medical Research Council, and is president-elect of the Federation of European Neuroscience Societies, and last year was awarded a CBE by His Majesty the King. Welcome.
Great. Well, thank you very much. I'm really delighted to be here to celebrate this important milestone. So thank you very much, Tim, for the kind invitation and the introduction. There is no doubt that the pandemic revealed to the world and indeed underscored, as I have said many times, just how important universities are in society and the role that they can and they must play when it comes to facing global challenges, as we have recently faced with the pandemic. But alas, there are many still there in front of us, and I dare say to come too. And having a strong science base, I would say this as a scientist, was key to navigating our way through that pandemic and getting out the other side. And so it goes without saying that naturally we are very proud of the contributions that you have made and we have made here, ranging from, of course, the Oxford vaccine to the topic of tonight's event, the Oxford COVID-19 Government Response Tracker. So over the past 3 years, I don't need to tell you this, but for those who might be unaware, those online listening, you have all built collectively this amazing, critical global public good, providing real-time open source data that has enabled, of course, the researchers to analyze the effects of different policy responses. And I understand there's more research now planned and to come, and you've had a good session this afternoon to take those ideas forward. Obviously, policymakers around the world to learn from each other, something that is always needed, much of, and to calibrate indeed their responses. And the public, of course, to understand what's happening and in a comparative evidence-based way, and getting that science communication into often contentious public debates. And this is an area that, again, I'm very keen that we do more of. And we think about how we can, again, have a better, well-educated public when it comes to scientific rationale and thinking when it comes to decision-making. The impact of this project that you've been a part of has been nothing short of extraordinary. There's been over 2,000 academic citations, as I understand him. It's been used by governments all around the world, the UN, WHO, and hundreds of news articles in dozens of different languages. That really is quite an extraordinary impact in such a short period of time. And none of that would have been possible without the extraordinary contributions of the volunteers. And that's why we're here tonight. We are here to celebrate the service of you, the over 1,500 volunteers who gave their time over the past 3 years to power the Oxford COVID Government Response Tracker. Your dedication has been amazing, working week in and week out to collect information on government responses, put them into standard comparable frameworks for subsequent use. And at times, I'm sure that work might have felt like you're in a silo and a little bit lonely, but they were, each element of it, a critical part of that larger whole that has made such a tremendous impact, as evidenced just now by the Director General of the WHO. So on behalf of the nation, the globe, and all my colleagues here at Oxford, I humbly thank you for that effort. And there is no doubt that this project, I think, also illustrates something else, which is close to my heart, and that is the important lessons that when we have these great crises and these big global challenges, it is extraordinary, I think, how people step up to the plate and they get themselves behind a joint, shared, collective, common purpose to do something extraordinary. And I've always been very vocal in my previous job as Warden of Merton College to just celebrate and congratulate the students. I'm going off piste a bit here from your thing, but it does need to be said because, again, it is linked to, again, what you have done, but that is to celebrate the fact that, you know, when push came to shove, you know, our young students sacrificed actually quite a lot of their normal expectations of a young adult life. And they did that in order to look after the vulnerable and the elderly. And I think we don't often recognize that enough. And certainly I witnessed that many times over in terms of seeing how the students, without any complaint and without any doubt, they, you know, took that decision to sacrifice quite a lot of their own personal freedom and enjoyment for the greater good, and particularly for the elders and for the vulnerable. And that is extraordinary. And of course, we saw that witnessed, you know, everywhere, didn't we? Whether that was, you know, neighbours doing shopping for each other, checking in on, again, elderly or the vulnerable. And again, in science, how everybody, again, got together behind that citizen science and showing just once again what an enormously powerful commodity that is and what a tool that can be. And I think fueling further ideas about how we can power that more going forward in other areas. I think another lesson that we learned is, again, the importance of multi and interdisciplinary research. This is something that we celebrate a lot in a place like Oxford, where we have great strengths across all the different areas, from the humanities to the social sciences, to the maths and physical sciences, medical sciences. And we create these areas and opportunities, these crucibles, as I refer to them, often in a college format, and again, in forums like places like here, where you can bring those different disciplines together. But we can do more. We can do a lot more of the interdisciplinary work and the multidisciplinary work, in my opinion, again, to tackle some of these big global challenges. And I think you have illustrated powerfully the benefits of that with what you have been able to do. Because pandemics, as we know, are not just a medical phenomenon, they are a social phenomenon, they are a political phenomenon, and they are an economic phenomenon. And so during the last few years, we have seen very clearly how good government decision-making has been critical in order to have an effective response. And we've also sadly seen where poor decision-making has led to worsening outcomes. And that is why it is essential that we have something like this, the Blavatnik School of Government, and social scientists across the university helping us to understand what policies governments are putting in place, why they are choosing different strategies, what effects they can have on behaviour, on the economy, and so forth. So I'm really delighted that Oxford has now established the Pandemic Sciences Institute, and that, of course, is going to be a fantastically exciting hub for pandemic responsiveness. Sadly, we will need it, I dare say, going forward, and we will have that preparedness for the nation and the globe, and hopefully for many, many years to come. That's the future, but for tonight, we are here to celebrate the achievements of everyone who's been involved with this project and has allowed it to thrive over the past 3 years. Our partners and advisors, our funders, the project team, and most importantly, those thousands of volunteers who have given up their time freely. So on behalf of the University of Oxford, I thank you for your dedication, your service, and your professionalism. You should be rightly very proud of what you have achieved, and tonight is your night. And so I hope you enjoy the evening, and thank you once again for including me.
Thank you, Vice Chancellor. I'll next invite my colleague and co-academic lead for the project, Dr. Anna Petherick, up here to lead an interesting panel discussion looking at the front line. So not just how do we track these policies, but how do we decide on them? Anna, over to you.
Okay. Well, it is my opportunity to say welcome to friends, colleagues, people I don't see often enough. We've had a pandemic, obviously. And again, to say, and I'll say this many other times today, thank you to the volunteers. A prominent purpose of the Tracker project was, I would say, to make life easier. I'm not sure that's the right phrase, to make life more evidence-based for decision makers in incredibly difficult positions. By showing them what other countries, other states, provinces, cities were doing, where they were making difficult decisions, and by giving information to modelers who could come back and furnish that information about what was actually working. So really to set the scene, because it's amazing how normality switches back, I want you to cast your minds back to just how difficult it was at the beginning of the pandemic. Those huge stakes and that wild uncertainty that decision makers faced. Not knowing if there would be, for example, subsequent waves. And in the case of the UK and India, those subsequent waves were enormous in their devastation. And so decision makers made massive, massive choices that are extraordinary in peacetime and affected us all, be that in terms of the health outcomes of people we loved. Someone I met this week went into lockdown with a couch surfer, a Colombian lady, the couch surfer in Italy, and married him a year later. So enormous consequences to many of these decisions. And so on our panel, we have 3 policymakers I'm about to introduce you to, who are all really in the hot seat, making those decisions in 3 countries that had very different stories of the pandemic. I was going to say, before I introduce them, I would like audience participation. So at least part of the way through, I will go to you. So if you have burning questions, there will be a moment, at least once, hopefully several times throughout the discussion. So I'll start with Mandip Bra, who I should say before we go any further has interrupted his exam period for this. Mandip is a current MPP student. He was also Deputy Commissioner. He ran the COVID response in the Indian Union Territory of Tangida. And he's worked for the Indian Administrative Service of 17 years. You have a vast range of policy areas of experience, from poverty alleviation, women's rights, urban development, all sorts. Next to me, we have Dr. Tuan, who's an economist from Vietnam, and he's also Dean of the Fulbright School of Public Policy and Management. In the summer of 2021, Dr. Tuan was called upon to serve as the Chief Policy Advisor to the Ho Chi Minh City government, and was also a member of the Prime Minister's Economic Advisory Group. So lots of experience there from a very different country, again, going through the pandemic. And online, I'd like to say a very warm welcome to Caroline Edwards, who is joining us from New York, but she's going to talk about Australia. Her job currently is Commissioner to the Americas for the Government of Victoria. But Caroline was Acting Secretary of the Australian Department of Health from February to July 2020, and then Associate Secretary from August 2020 to July 2021. So a wealth of experience, adding, I might add, to the experience in the room. But I wanted to start with a very simple opening question to each of the 3 of you, and that is, when you first rolled up your sleeves and had to deal with this huge problem, but we didn't know how huge it was, what approach did you first take? And how did that begin to evolve early on? So I'm going to go to Mandip first.
I think when we started first, primarily there was more of a regulatory and a reactionary response, because we didn't really know much about the pandemic. We didn't really know much about the virus. It was based on what was happening at Europe at that point of time. And I remember I issued the curfew order for Chandigarh on the 23rd of March, 2020. So immediately we put incident commanders, we used sector response teams, a control room, getting together with all the health, the civil surgeon and all the heads of the health department and the hospitals, and finding what to do, and looking at essential services, and a lot of providing immediate relief to people who were actually part of the lockdown. But then as we developed, of course, initially the focus was totally on containment and stopping the spread of the virus. And I can recall that initially we had very strong teams for contact tracing. On an average, we were contact tracing 20 people. And the idea was and we had a lot of quarantine centers. But as time went on, of course, the focus went on towards home isolation instead of containment or micro-containment and so forth. And of course, building up of the medical facilities and focusing on the more vulnerable sections. That's I think, primarily how it panned out across the world. And that was true there.
Dr. Tuan, what approach did you take? And obviously it was a different period of the pandemic.
That's right. The story of Vietnam is quite different from many other countries. First of all, we are very close to China. We have hundreds of kilometers of borders with China. So the first thing we do, and actually we learn from SARS, which is to close the border with China. So that is among the very first thing we did. But then actually the situation of Vietnam, the COVID-19 Vietnam in 2020 is quite, it's not dramatic at all. So the governments decided to put a very strict social distancing in March and last for 3 weeks. And after that, we couldn't try COVID-19 at all, right? So basically, we was able to contain it in the last 3 weeks of March and early in April. But then the problem is, we somehow feel, there's some kind of complacency. So during, in the next year, when the COVID-19, when the Delta variant came to Vietnam, we were not prepared. So, many people, when we talk about the Vietnam experience, talk about the success of Vietnam, but mostly for the first and half year, but then from the summer of 2021, when Delta variant came to Vietnam, we were not prepared. And then the situation becomes, when can we secure vaccine? So at that time, vaccine is the only possible solution. And when the problem became so serious, which is by July 2021, less than 5% of Vietnamese population have the first shot of vaccine, which is very late. And in the Vietnamese government budget for 2021, there's no budget line for vaccination, which is a big mistake. I can come back to that, how government response, but that is a big mistake that we missed. But then the good thing is, once the government recognized that mistake, they try very hard to secure a vaccine. And after 4 months, the vaccination rate for Vietnam reached about 70%. From end of June to about November, we were able to secure enough vaccine to provide vaccines for about 70% of the population. And then we started reopening the economy by then. So that is how Vietnam is quite different from other countries in the world.
And you, of course, you had movement restrictions all the way back in January 2020, right, which is a unique.
Quite early. Yeah.
So Caroline, let me turn to you. Same question to you. Tell us a little bit about your approach early on and how it evolved, because you were there right at the beginning.
Hello, everyone. Can you hear me okay over there all the way? Thanks very much for the invitation. And can I just add my thanks for the tracker and all the volunteers, because it was relied upon by all of us all over the world, and also acknowledge the incredible work that was done in India and Vietnam that we also followed. I'm a bit of an accidental contributor to the pandemic. I had actually moved to another role outside health in broader social policy, but our chief medical officer was due to move into the role of secretary just as the pandemic was starting, and there was a decision that he should stay where he was for the moment. So I was asked to come back and fill in as the Secretary of Health for a month before my trip of the lifetime to India, which was all booked and paid for and everything. So on the 24th of February, I went for a month and was there for 18 months. During this extraordinary period. And like everybody else, it was probably the career, both highlight and most difficult thing of our lives. But I would say that I don't feel like I was on the front line. I think the people on the front line were really the doctors and the nurses and the health workers, and also the bus drivers and the supermarket workers and all those other people. But we certainly worked hard. I think the key thing in February is that we didn't know what we were dealing with, and it was all much bigger than we expected. So we effectively divided the work between the Chief Medical Officer, Professor Brendan Murphy, who dealt with the states and territories on all of the things like social distancing and crowd limits on crowds and all of that stuff, whereas I led the department in preparing the health service for what we didn't know would come. So increasing the capacity of ICU beds, making sure we had equipment, PPE and ventilators and so on. And also looking hard to see how we can ensure that ordinary medical services continued even in the face of the pandemic. So we rolled out universal telehealth so that practitioners could continue to see patients and patients could continue to see doctors when we didn't know what was to come. And the key thing I remember from that period, the key things, one was we cut through an enormous amount of red tape, which would normally have been the case for policy development and implementation in Australia and probably everywhere. And that was difficult decision making because you can't get rid of everything. You still have to have checks and balances and take care, both in terms of clinical safety and so on, and also financial responsibility and all those other things. And the other thing is that we just completely underestimated the size of the thing. So the first package we did on about the 8th of March seemed to us to be the hugest, quickest, most amazing health package that we'd ever heard of in our careers. And of course, it was dwarfed within a very short period as the costs and the measures that were needed in Australia as elsewhere just accelerated. So I think our approach was really to try and be as science-led as possible and respond both in terms of how we asked our citizens to behave in order to reduce transmission, which hadn't really arrived in Australia in a large degree at that point, but also build on our existing health systems and so on to be ready. And at the same time, we were watching what was happening overseas and thinking that could easily happen in Australia too. How are we ready for it? And how do we engage with the rest of the world to really accept best practice and do things in the best possible way we could, given we had such a lack of information and we were really just acting as quickly as we could on the little information that we had.
So we like talking about information here. So I'll tug on that point a little bit and ask the two of you what Caroline was getting at, and that was really measures to address uncertainty. So how did you deal with uncertainty? How did you draw on experts in that early phase? Let's go to you, Mandip.
Yes, initially there was a lot of uncertainty, but in Chandigarh, we had a system where there was a daily war room meeting headed by the governor. So you'd had even people from the neighboring cities, but at the district level, I was heading an affected areas committee meeting with the Commissioner of Corporations, Superintendent of Police, the Civil Surgeon, heads of IMA, some of the major hospitals, head of our contract tracing teams, and our local representative of WHO, who very kindly attended almost all those meetings. This was a sort of a brainstorming. In the sense, we all put our head together and tried to see what is happening in the rest of the world. So we'd have the latest trends. We'd see what is happening, what is needed. We'd assess our weaknesses. Then we'd also decide there in that meeting only what containment zones to have, where to beef up medical supplies, ways of seeing how we can augment the existing strength of hospitals, beds, get retired doctors and paramedical staff on board. And there was a total assessment of that. And quite frankly, in the initial days, most information was based on news reports, television, or the help of some epidemiologists who were getting information online, whatever best they could across the board, or based through personal contacts and so forth. But over a period of time, Government of India, I think, also stepped in and had a uniform bulletin and a website, and that provided information across the board, basic information to all the states and union territories, which was very useful because we had a basic inkling of what was going on across the world and what is primarily going to hit us in the next weeks, or so to say. And then we could modify and plan accordingly, according to our local need and requirement.
So I think it's a topic for much discussion is what structures emerged for governance during the pandemic and what is useful perhaps to take forward for pandemic preparedness, but also for public health more broadly. Did you have a war room, Dr. Tuan?
I share everything that Mandy just said, but I think I would provide another angle to that from the policy perspective. At that time, basically, everything is uncertain but the pandemic. So if we talk about the source of uncertainty, there's so many that you can probably not be able to list them all. But in different periods of the pandemic, there are different kind of uncertainty that emerge as something which is the biggest concern for the policymakers. Let me give you several examples. For example, for the first period of the pandemic, let's say for the spring of 2020, the most important thing that the Vietnamese government want to find out is how far the virus has spread. Basically, because otherwise the containment efforts will be like futile, right? So that is tracing, quarantine, and so on and so forth is the most important policy instruments. But then, when the Delta variant came to Vietnam in the mid of 2021, then the biggest question is, when would we have the vaccine? And basically, that at that time, as I said, only 5%, less than 5% of the population gets the first shot of vaccine, first dose of vaccine. And then, it's really hard because the demand is so high, the supply is limited. So how come Vietnam can get vaccine? Without vaccine, how can we deal with the pandemic? So that is the most important source of uncertainty. But then when the pandemic passed for about 5 to 6 weeks, and it's really tests the patience of businesses and of the people, then the next important question, the next uncertainty is how far the people and the business can stand the very strict social distancing. And at the time, we were several group of researchers looking from, in the experience from the world, and we came to a threshold which is about 60 to 70 days maximum, no more than that. After that, people can get crazy and people can go on street to protest. And actually, Ho Chi Minh City put strict quarantines at that time, only second to Wuhan in China. Very, very strict. Basically, you are not allowed to go out. And then it's already 3 months, which is probably now when I look back, it's a horrifying experience. And another thing is many of the workers are very poor. They don't even have savings. How can they survive in that 3 months? That is so difficult to deal with. And then it's not only a medical issues, it's also social, psychological and economic issues, how to deal with that. So, what I mean is there's different sources of uncertainty and you have to deal with all of them. Of course, probably in different periods, there will be different kinds of uncertainty become the most important one.
So I'm going to ask one more question before we open up. And I think this idea of how much can people handle was a really pressing concern for quite a lot of policymakers. But I also know from chatting to Mandip that some extraordinary efforts were made to engage with citizens with extraordinary success as well and innovation. So I'm going to ask Mandip to tell everyone a little bit about some of the out-of-the-box thinking that you did.
I think it was, as was said, it was extremely difficult in the beginning, and especially the containment zones entailed a lot of difficulties for the citizens. So we started, and on the very third day, I had a video conference with all the resident welfare associations, actually explaining to them the need, explaining and taking cooperation from them. And I would say that throughout the pandemic, our strong interface with the community and our coordination with them made all the difference. And just to quote a few examples, for example, for 2 to 3 months when you're not working, when you're at home, there's going to be a lot of problem for many people to get 2 meals a day. And we are a population of 1.2 million, and we do have a lot of population or daily wage workers. So we needed to ensure that food packets reach all of them. So instead of just the government doing something, of course, we did start kitchens. We started kitchens at our tourist hotels, which were vacant. We started in our school midday meals, even in our prison. We used that. But we reached out to all the religious organizations, the social organizations, the political parties, and they responded very well. So we set up a system whereby everybody cooked food packets according to their capacity. We would collect it and have a system of distributing it with social distancing. And the response was tremendous. We even had students saying, we just want to cook 10 packets and we want to be part of it. We collect it. And at the distribution points, we had some of the bigger contributors there, not just for as a check, but to have an emotional connect with what they were doing. And with a population of just 1.2 million, at the peak, we were distributing 170,000 food packets a day. And 75 to 80% of that was voluntary through this community leadership. And I think that made all the difference. And similarly, initially, we counted a lot on people to get masks or sanitizers everywhere. But over a period of time, as the pandemic on, the nature of that requirement changed. So if we had, let's say, Rotary or somebody saying we want to contribute, so we said, we don't want money. Get us a ventilator from anywhere in the world. Get us oxygen concentrators. So people did that. People went there. And I think that was part of it, because as Wu was saying, that we needed to look at different aspects, because one thing which we realized crucially initially was that we need to ramp up our health facilities. And we focused on that, and that actually paid us dividends, because between the first and second stage and the third stage the next year, when there was a huge oxygen shortage, in Chandigarh, we had 3 new oxygen plants under the PM CARES fund, which were constructed within that short period of time and were working by March 2021. That was an increase of about 25 to 30% of the oxygen supply of those hospitals, which meant during that time period, we were sufficient in oxygen. And a lot of the other stuff was actually with the help of community. For example, the Red Cross, the chairman is the deputy commissioner. So we started an oxygen concentrator bank where we can just give it to people for free, just send it, train them, and they can just use it till they want it. And all the concentrators were donated by different people. So I think the engagement with the community, getting them to be part of the effort actually helps. One, of course, there won't be that sort of dissatisfaction at the basic level. But secondly, it acts as a very, very important multiplier effect. We could not have got the same effect, the same outcomes if the community, if different segments of society were not working with us, all the professionals, all the industry bodies, the religious bodies, the political parties, etc. So that's a way to, I think, tackle.
So just to be clear, that is using the public bus system to collect lots of meals and then drive around and then let people come and get meals.
That was different. That was different. In fact, I remember on the very third day when we imposed the curfew, on the third day, we realized this is not a normal curfew. In a normal, I mean, if there's a law and order situation, you typically have 1 or 2 hours where, you allow people to go out and purchase food or something else. Over here, you can do that. That would have defeated social distancing. The people would have just crowded around. So we stuck upon an innovative idea. All our state transport buses were lying idle. So we actually converted them into mobile markets. We had vendors with fruits and vegetables. So about 150 buses spread across, divide the city. So you had a household that just the horn and people would just, with social distancing, line up and so forth. So yes, those were some interesting innovations we had to do.
So what I really like about Mandip's constant engagement with the community is, you were telling me earlier how this really paid dividends down the line when it came to vaccine hesitancy, for example. This trust was built up through constant engagement. I want to turn to Caroline, because Australia had such a completely different experience, especially early on, and ask about how you communicated what was going on to a population going through something very different, watching the rest of the world seeing much more dramatic case rates and so on. How did you communicate and engage people?
So communication was probably one of the hardest things we had to grapple with, and probably the one at which we made the most mistakes and had to revisit our position so many times. I mean, like many other places in the world, the Prime Minister and the Chief Medical Officer and the Premiers and Chief Health Officers of the states were having basically daily press conferences, which is not a normal thing in Australia. So it became the norm, getting up and hearing from the most senior medical officer and the most senior political officer of each jurisdiction what's going on, where it's up to. Because the first challenge was to really get across that this was serious. And we had to take, I mean, the very first day that we said you could only have 500 people at a football match or something, people were saying, are you serious? This is crazy, which of course was nothing compared to where we went. But getting that across was originally a real problem. So doing those things were really important, but also what we're really conscious of, and this was so difficult, getting to parts of the community who would not necessarily be listening into those daily teleconferences. So trying to work through peak organisations, both with business and unions and so on, but also with community groups, with disabled providers and communities, very important with our First Nations communities, particularly remote communities. We were aware with the health, with the burden of disease in those communities, that if COVID got into one of those remote communities, it could be absolutely devastating. So that was a fundamental priority. Now, how we pulled this off was varying. It was all in the context of people suddenly working from home. My own department of 4,000 people went from everybody in the office 5 days to 90% at home 5 days within a 2 or 3 week period. So doing communication that way became incredibly difficult. But we found ways to manage it and to do video messaging and all of that sort of stuff. But it was a constant problem. And the other thing that made it difficult, we were proudly a health-led response all the way through, as were my colleagues have been talking about. But because the health advice changed, as it does when science is discovering things, we then had to think about to what extent do we change our messaging. So we all remember early on when people were washing groceries and things like that, that later became not the thing to do. But you go out and spend your time telling people to stop doing things you already told them. So how do you make sure you message properly? And for us, masking was a really core issue in that regard. Early on, we were doing what was then the pretty standard advice that masking for non-frontline health practitioners was probably not required. If you don't wear it properly, it can be counterproductive and so on, all the way through to later on when we know that masking was a key part of the public health response. But it's very difficult to change that messaging as you go along. So one of the things we talked about mostly was how do we make sure we get the right balance, and sometimes we struck it right and sometimes we didn't. But I think going forward, that's one of the things I would think really hard about. How do we make sure communicating in different languages to different communities for different reasons, and how do we deal with uncertainty in communication? Because we all know simple messaging is the best. but this was not a simple situation. Now, we're proud of where Australia came out of the pandemic and how we did it, but there's certainly a lot to learn, and how we make sure we bring along the population, which I think the Vice-Chancellor was making the point earlier on. Enormous numbers of people in Australia and everywhere made huge sacrifices in order to protect the vulnerable and the elderly. And we need to make sure that we have mechanisms to explain to them why that's the case and to acknowledge that behaviour afterwards. I hope that answers the question.
Yes, thank you. So I'd like to open up, if anyone has some, we do have burning questions. Please tell us your name and your interest in COVID.
Mario Marcet, thank you very much for hosting this event for us. I work in risk policy at the European Bank for Reconstruction and Development. We are one of the bigger lenders to smaller and medium enterprises in emerging economies. So thank you very much for sharing that. This is the reason of my background, why I'd be so interested in finding, since many of the initiatives you took were in sourcing vaccines, speaking to likely manufacturers and vaccine developers, or any other initiative that could have helped the public. I wonder, what good experiences did you make as great policy leaders that you are in your countries with the private sector? Sort of what insights did you draw from dealing with them?
What insights did you draw from interacting with the private sector? Dr. Tuam, would you like to take that question?
That's a great question. And Vietnam is a socialist country. So, you know, talking about the private sector and letting the private sector to take the lead is something unimaginable in the normal time. Right? But during crisis, everything can happen, and all the rules can be overridden. And at some point, okay, let me tell you the experience of Ho Chi Minh City, because it's where the pandemic get more serious in Vietnam. Ho Chi Minh City has about 12 million people, very big population. And it is the richest city in Vietnam. It's a commercial and economic center of Vietnam, contributes about a quarter of Vietnam's GDP and a quarter of Vietnam's budget. But after 2 months into the pandemic, it ran out of money. No remaining resources can be used. At that time, Ho Chi Minh City had to either wait for the subsidies or transfer from the government, or mobilize, its own resources, and that's exactly where the private sector comes into the whole picture. But at the same time, the private sector were not allowed to participate in every, part of the pandemic fighting strategy. Basically, the private sector can provide the equipment. Most of Ho Chi Minh City's few hospitals were built by the private sector. And unfortunately, the women who donated those few hospitals are now in prison. So I want to lay it out, just because there's so much risk and uncertainty from the side of the people who made decisions at that point. Because in many cases, you need to go beyond the current rule. And then at that time, it can be justified by the crisis. But later on, when someone revisit everything, and then those people in great dangers, I don't mean to say that that woman got into prison because she donated, right? It's not the thing that I'm talking about. I'm talking about here about the risk that the private sectors may suffer. Another, which is very important thing, is the private hospital in Vietnam were not allowed to participate, which is so unfortunate. That is a big mistake. That I hope that in the next pandemic we need to learn that lesson, because the private health sector in Vietnam accounts for about, especially in Ho Chi Minh City, account for about 50% of the total capacity, and they were left idle for most of the time, which is and during that time we are in shortage of everything. And the last thing, which is very important, is the civil society. It's a little bit different, but at some point in the middle of the pandemic, the leadership of Ho Chi Minh City recognized that we have 1,500 blind people. And, without anyone who approached them, to support them. And that's where we need to rely on the civil society. And in normal times, civil society is not something which is welcome in Vietnam, as in other countries. So mobilizing every resource possible is key to the pandemic, but you need to be inclusive. The system needs to be open enough so that they can mobilize resources from different sources. And I think that is a big lesson that we would learn from this pandemic. And the most important thing is try to avoid many mistakes that we have made. So that's probably the first critical step.
I think that's what the Pandemic Sciences Institute is really going to try and do, among many other things. So I'm keen to take more questions from the room, but I did just want to ask if our other panelists have anything burning to say on how relationships with the private sector developed or learnings for the future.
Well, I think in the Indian context, and especially Chandigarh context, we had a very good relationship. As I've already pointed out, we had a lot of things. They just filled in many of the gaps and helped us out. In fact, during the third phase, when we saw that we were sort of going to reach a situation where our bed capacity was going to be quite full, we in fact talked to many of these organizations, and we had 7 mini COVID centers set up at that time within, 10 days. And these were managed by a couple of them by religious organizations, some by Rotary. One was by Rotary, some by industries, and they basically had retired doctors, nurses, or some who were on leave, doctors from across the world who were leave stuck there, or some in the private sector who were not working at that point of time. And all 7 were attached to one of the hospitals for the site. And it was really good because we were able to create a space of 500 beds, oxygenated beds, which took the pressure off the main hospitals for the more serious patients. And I think, so that's why I say that, of course, once the government of India had taken care of the guidelines and everything and a bulletin and see every second day, but at the local level or at the city level, etc., I think it's for the local administrations to liaise with the private sector, with civil society, be more innovative within the government and take care of things. So to answer your question, I think, yes, it was a very, very strong engagement with the private sector also.
So I am going to push to Caroline quickly, but I want to put a bit of a spin on it actually. So feel free to answer that question, Caroline. But I also wanted to learn a little bit more, and maybe you could share with the room how some of the structures of decision-making in Australia actually changed, because in Australia, so many decisions are made below the national level, but new structures were created during COVID. So please feel free to come in on the issue of the private sector, but also please tell everyone what happened in Australia.
Oh, well, the two questions sort of merge. So I think it's fair to say what we did in Australia was build on existing structures as much as possible, both at the federal level that I was involved in and in the States, knowing that as soon as you create a new thing, it's disruptive and difficult and set up and so on. The big change in Australia was the creation of what's known as the National Cabinet, which was really a meeting of the Prime Minister and all of the premiers of those and chief ministers of the 6 states and the 2 territories. And that had been a similar, there was a process for that, but it was cumbersome, paper-driven, slow, combative, politically charged. And at least for the initial period of the pandemic, I mean, politics came back at some point, basically most of that was stripped away, and it was a group of 9 people plus on occasions the chief medical officers and so on, in a room working out what was best for Australia. An incredibly inspiring thing for Australian citizens, and helped people make the decisions they needed to make to comply with the rules. So that was a huge thing. But in addition, in response to the question about private enterprise, I was really delighted and excited about how much private enterprise was part of the social policy response. It was a health-led response, the focus of which was to reduce to the greatest extent possible death and serious disease from COVID and from other things. Now, that's not the profit motive that businesses normally are going to talk to their shareholders about, but they were absolutely on board, all the way from the smallest businesses up to the biggest in terms of contributing, getting together to find ways to build ventilators. And every small business that turned its business overnight, restaurants from restaurant to a takeaway, cheerfully, and it was an extraordinary effort. And that became part of the way structures were built on. So including the peak bodies of businesses, talking to them, talking to unions and other things was great. And things like including the private hospital sector, hearing about the experience in Vietnam is very interesting. But the private hospital sector, there was a ban on elective surgery at one point because we wanted to reserve ICU and other facilities. Now, those hospitals would have gone broke, obviously, because they couldn't do elective surgery. So what happened is the government came in and gave a guarantee, and in exchange, the private hospitals offered up all of their staff, all of their resources, all of their equipment. Now, that sort of governance to do that and arrangements to do that meant we had to have Commonwealth, state, private enterprise, public hospital agreements finalised in, I think one of my teams did it in 10 days. Now, that's unheard of, to have a huge financial and administrative. So, an incredible demonstration of what we can do when we have to. And I guess the challenge going forward is, how do we bottle that sort of fast, effective action that actually includes people and is all with a common cause? That was one of the great things about the way people work together. And also in the international forums that I was involved in, WHO once and so on, also saw an enormous sharing and openness, which is not always present in those forums. So really was very impressed with many of the colleagues I heard speaking from both our Western Pacific region, but also across the whole of the world.
That's very true to the tone of the tracker, I think. So I'd like to open up again to questions. I want to take a couple, and if you could say who you are, but also if you have a question directed at anyone, that would be very helpful. Yes.
Hi, everyone. My name is Sumis Sibakoti. I'm currently a student at Central European University, Department of Legal Studies. I was in Oxford. I'm in Oxford for my research. I just got lucky to attend this conference in person. So, if there is one thing that this pandemic taught us is the moral imperative to take care of each other and how interconnected the world is. But as we turn the chapter to the post-pandemic time, one of the negative legacy, one of the bad thing that will stick with us, I believe, is the public distrust on science. I was in New York. I was living in New York at the time when pandemic unfolded. I remember the government instruction that you don't have to wear the mask if you are not under certain conditions. And after that, it changes. In New York, Governor Cuomo would come to television and say one thing today and say something else. After a few days, same thing, Dr. Fauci. Of course, they were speaking based on best available science at the time, right? But many people, especially many public, don't understand science and the nature of science as much as most of us in this audience do. So still right now there is not very consensus. So I'm wondering, how as we move away from the pandemic, when the leaders will try to say we are using science evidence-based decisions that the Blavatnik School of Government talks about, do you think there is some unrecoverable ever damage to the use of on the science, especially in public eyes?
Question. Okay, can we recover trust in science? There was another question here.
I'm Madam Romina from the ESOC Center, and I'm interested in the political economy of knowledge, and particularly some of the ethical dimensions of the use of knowledge and evidence in policy. And I've been working quite intensively in the last 3 years on expertise under pressure, as it were. So one thing, things that happened during the pandemic was that there were league tables of countries, right? And countries moved up and down these league tables, and Australia, New Zealand, and Vietnam up and then down. And so I'm really curious to ask any of you, how did you manage those international comparisons? Who did you learn from? What learning did you do? What learning did you get from these international comparisons? How did you gauge what you were learning from other countries versus your local context? I suspect it's very difficult. Very difficult to apply lessons from other countries to your local context. And related to that, I mean, the WHO talked about the infodemic, and I'm really curious to hear from you how you weigh scientific advice and weighed evidence and navigated perhaps false information or not sound information amidst this sea of evidence we were bombarded with.
So some big questions there. Andrew Pollard, I was going to stop, but since it's you, what's your question?
Vaccines. My question is really about this issue of thinking about the central coordination of things and what Andy was saying about the bottom-up approach. But I think if you look at the UK, there was a lot of complex things which were done centrally, whether it's sequencing or contact tracing or vaccine rollout. Hard enough to make the policy decisions, but often even harder to implement them, particularly in the lowest resource settings. I had the experience a couple of months ago of having dinner with the Dr. Faisal Sultan, who was the health minister in Pakistan during the pandemic. And this was what he was faced with, was the policy decisions were hard enough, but then he had to think about how do you implement them across a large federated country. And in fact, the only way he could think of doing it was through the one institution which is properly national and well organised, and that's the army. And it was very effective that he was able to do that, and they had a very good vaccine rollout. And they managed to do quite a lot of contact tracing as well, very efficiently. But there weren't other national institutions. I'm just interested to know, particularly from an Indian perspective, another country with many very large states, some of them larger than this country, and how the national coordination worked in relation to the bottom-up approach which you described.
For anyone who doesn't know, Sir Andrew Pollard led the vaccine work in Oxford. So 3 questions. I'm going to suggest that one of you takes one of them, so we'll spread them around evenly. Let's start with that last question. I'm going to demand it, since the question was kind of turned towards India.
I think what I would say is that in the Indian context, we had a very nice balance, in the sense that based on whatever was happening across the world or whatever learnings we were getting, the government of India was coming up regularly with certain broad guidelines, certain broad do's and don'ts. And the very nature, the structure of the Indian nation is that the state governments actually have to implement all those things. So while Government of India provided the guidelines, Government of India provided the wherewithal for many of those things. It's the state governments which were actually implementing them on the ground. Let's say, for example, vaccines. Now, the entire vaccine, the stock was centrally sent by Government of India, allocated to states, and the states would be told, on this date, you would get this stock of vaccines. And I can say for Chandigarh, we always got it on the date exact. So now it's a job of the local government to actually foresee the date, to plan, and to make sure that the vaccine reaches people it does. And if we are going to face some sort of a shortage in future, we inform Government of India well in advance and say, maybe in some state, the vaccine takeoff hasn't been so good. Can we have it? So forth. So, and when I gave the example that we would have a war room meeting, the governor, and even it's a tri-city Chandigarh, 2 states, but it's also the joint capital of 2 states, Punjab and Haryana. So in the war room meeting, all the people who mattered for policy, they would be on board so that everyone is of the same thinking. And in the affected area committee meeting, which I was talking about, all the decision makers on the ground, relating whether it's the municipal corporation, it's the police, it's the health department, of course, it's our contact tracing teams, everyone was there. And as a special invitee, we'd always got the WHO, Dr. Srinivas, I remember he used to come, and some epidemiologists from PGI who'd always be there. But ultimately, we are the ones who know how contact tracing has to be done. We are the ones who have to make sure that if the government of India has given a certain guideline, we have to implement it. And I would say that in a huge country like India, as you mentioned, the context and situation of every state is different. So this has to be delegated. While you can have broad guidelines that this do's and don'ts, let's put it this way. But within that, to put all the dots and the picture and to give it finality, it's the state government which has to do it. I mean, nobody knows, whether in my jurisdiction, it's the civil society or the private sector or what is going to work. Now, for example, and the idea is at that point of time to look at your strengths. I was giving the example of the bus, for example, but even the staffing for contact tracing, a huge chunk of the team was from the municipal corporation. For the simple reason, they knew each and every alley of the city. So they'd actually reach there. Or let's say for distribution of food, we used sports department coaches. I mean, that might sound odd, but they were really good at ensuring people who line up, they'd put those white dots there for social distancing. It was very effective. So, I don't think at the national level, nobody can even, and nobody should. They should be thinking about larger issues. They should be thinking about where to get the vaccines, where to get funds, or where to provide that wherewithal or the latest scientific evidence. But to do it efficiently, one has to do it in the field, but most importantly, it has to be coordinated. All the stakeholders. And as I said, it's not just the government officials which were there. The Indian Medical Association, we used to call them. The private sector was very much there. And the private hospitals, they were taking on the burden, though we did do one thing. We put a cap on the treatment prices at one point of time because we got, through executive orders. And we did that. So the idea is there has to be a very delicate balance between them. But no, centrally, I don't think that's a very efficient way of doing it. But yes, to have a responsive center, which is providing you all the information, is there to help you out, combined with responsive. So it's top-down, bottom-up meeting somewhere in between for an equilibrium. That's what I'd say.
There you go, work from your strengths. So Caroline, to turn to you online, I'm actually wondering whether you'd like to take on the question about managing the international comparisons in those discussions, because you must have felt like, along with New Zealand and a few other countries, a bit of an outlier in terms of what was going on. How did those discussions go?
I think the first thing to say is that at every stage, we wanted to make sure that we weren't smug about it. We were very lucky in Australia because of our geographical borders, the fact that our borders closed early, and it wasn't lucky at all, but we just came out of those terrible, terrible bushfires, which meant that travel within and into Australia was reduced. So we're enormously lucky not to have that initial. And then I think we did some good things to stop the spread and so on. So we were very low levels of COVID for a long time, and we knew that what we needed to do is get the population vaccinated before it came. But obviously in 2021, after the vaccination, we did have very high numbers of COVID. And, there is a lot of analysis to be done going forward about excess death data and so on. And but there's probably not much to be gained by saying who was at the top of the league or at the bottom of the league, because so many factors were going on. Having said that, we were very pleased and grateful to have so little COVID for such a long period. And we were very conscious to look at what was going on around the world and try and get bits of best practice that we could use. I mean, we're also like a relatively wealthy nation, so we had one with a strong safety net and so on, so we could do some of those economic measures, like a lot of the income support and so on, and for both businesses and individuals, so that people could stay home and isolate, so they didn't have to work when they were sick or at risk of being sick. But at the same time, we looked around in places like Vietnam. We were very impressed with some of the things that were happening there and seeing how do they relate to us. So the challenge was to be part of the the international community on this. That was a problem for all of us. Viruses don't respect borders, and also to respect all the work that had been done all around the world within the constraints that they saw and learn what we could, and also to assist. So we tried very hard to assist where we could. We did some assisting in India, but also in our region in the Pacific and so on, and to be part of international forums in a way that really helped. I mean, league tables, there are some countries in the world who had terrible spikes and death rates and so on. We couldn't necessarily point to anything that's the fault of their policymakers or anything else, and we should be really cautious about doing that. But learning from it going forward. So I think Australia did really well. I'm proud of the work we did, but we're also fortunate, and we came from a strong base, and we've got a lot of respect for a lot of the places and those that were in the depths of very difficult times, how they responded to it and worked notwithstanding is really to be rewarded and respected just as much as those places like Australia that had low numbers for a long time until after the vaccine, and hence we think low death rates.
Very valuable points there. Now, we did talk before, and I did say that I did want you to talk a little bit about trust. So it's very helpful that a question about trust has come up. But dare I ask you, do you think trust in science is recoverable? But please do dispel some words of wisdom about how Vietnam managed social trust.
Probably I will talk about the experience with the scientists first, and then going back to the social trust. Of course, I'm not speaking on behalf of the scientists, and there's many distinguished scientists in the room. I'm looking at it from the policy perspective because I'm a policy advisor. And the first thing I would like to say is Vietnam faces quite different issues compared to other countries. For example, wearing masks in other countries should be enforced, for example, but in Vietnam, people wear masks in everyday life. The main thing is because there's pollution, air pollution, and even before the pandemic, Vietnamese people already wear masks on the street. So asking them to wear the medical mask is not an issue at all. And another thing is, getting vaccine, for example, being vaccinated. For many parts of the world, vaccines were available, but then many people didn't want to take it. But in Vietnam, many people would be willing to bribe the nurses and the doctor to get vaccine. And on the social media, there's many stories like that. People were willing to, give like $100 or $200 to get the first shot of vaccine. And, that is not a small amount of money in Vietnam, especially given the standard of living. So we don't have that issue. But one thing I'd like to focus on, which is the evidence-based policy decision making. This is the real story from Ho Chi Minh City. So when the pandemic kicks in, there is a kind of procedure of treatment for the patients in the hospital. So they divide the hospital into 5 layers. So the first one is just, when you get in, you get to the first layer, and then when it's getting serious, you move up, and at the end, you go to ICU. And when we look at the data, we found that 34.2% of the patients die in the first 2 days. And then more than 50% patients die in the first 5 days. And then when we talk with medical doctors and so on, they said, this is the symptoms of they getting admitted too late, right? Because otherwise you can do something. And here, more than 1/3 just die before the doctor could do anything for them. That means there's a lot of issues at a very low level, even before they come to, even before they are admitted to the hospital. And then, because there are 5 levels, it's really hard and confusing for the doctors to get from one level to the next. And therefore, many people actually, they could be treated early on, get delayed. So then, with those information and with those data, and then after consulting with the medical doctors, our team suggested to the government of Ho Chi Minh City, that is to reduce 5 levels into 3. Basically to simplify the whole process. And then we try to support the commune level with medical devices so that they can approach the patient, so that the patient can get to the oxygen as soon as possible. And then it comes to the question of military. This is because in Vietnam has a big military, and this is something I would never forget. As Ho Chi Minh City has 212 communes, and we do everything, but then hundreds of people die every day. At some point, there's I cannot tell you how desperate it was. But then the central government decided to send the military medical doctors. And how many people they send? They send to each commune 2 military medical doctors. And with those 2 military medical doctors, they can help the local level staff to get the first treatment very effectively. And the death rate reduced significantly immediately, which is amazing. So that is the thing that, and that is the cheapest and most effective intervention ever in the whole pandemic. At least from my observation, there might be other, but it is something that I observed so clearly, and it takes place immediately.
So lots of insightful lessons and lots of conversations to be had with policymakers who have these rich insights of what worked and what didn't. And this will not be, unfortunately, our last global emergency or probably pandemic, as Dr. Tedros said. So it's time to unfortunately move on, but to thank our panelists. Thank you all so much for sharing your pearls of wisdom and for your contributions during the pandemic. And I hope very much, Caroline, that you do get your trip of a lifetime to India after all. I'm going to hand back to Tom. Thank you.
Our panelists for those fascinating insights. We're now going to switch gears in the final segment of this discussion, look forward and think about how the lessons of the last 3 years shape what we should think about in the next years to come. And obviously we in the project have a big trove of data, which we want to work with the whole world on digging lessons out of, but also to think about how we can engage with policymakers to ensure that systems for data provision don't only rely on universities. Universities have a vital role to play, but also how we build more robust systems going forward. But I'm delighted that we have 2 final speakers to offer some thoughts on the way forward, one closer to home, one further from home again. And the first I'll introduce is Professor Sir Peter Horby, who is Mo Family Foundation Professor of Emerging Infections and Global Health and Director of the Pandemic Sciences Institute. And Peter is an expert in many things, but I believe interestingly also set up a research center in Vietnam a number of years ago, so has a connection to our discussion already. He's also the executive director of the International Severe Acute Respiratory and Emerging Infections Consortium and co-chief investigator of the recovery trial here at Oxford, which studies therapeutic treatments, and has advised a number of governments and international organizations. So Peter, please welcome, you're very welcome, and we look forward to hearing the role of the Pandemic Sciences Institute in the next steps.
Great, thank you. That was a fascinating panel. It's really great to hear, some frontline stories, so lest we forget how bad it was. And as we heard, I spent 9 years in Vietnam, so it wasn't a surprise to me that Vietnam managed very well at the start, but a very challenging context. It's really great to be here because actually what took me into infectious diseases when I was at medical school, thinking about what specialty to do, was the thinking that, it's not just a medical issue, infectious diseases. If I have heart disease, it doesn't affect your risk of having heart disease. If I have cancer, it doesn't affect your risk of having cancer. But if I happen to have Ebola right now, well, that's a different circumstance. And it's ecological. We've heard a lot about the bats and the transfer and zoonosis and how we manage the ecology. It's very social, it's very political, and it's historical. You can look back over many epidemics and see very similar patterns emerging, and we keep reliving the same history, and it's very sad to see, really. And then my very first medical job was as a junior doctor on an HIV ward before antiretrovirals. And that really that locked me into infectious diseases, because seeing the terrible illnesses, but also seeing the social stigma, the responses to HIV, the inequity in Africa and other countries. It's the most fascinating medical specialty for me, and that's why I'm really committed to it. So the title I was given was The Way Forward, What Can We Do? And I'm going to talk from an academic point of view, because I think the next speaker will talk more about the broader policy issues. I think what we can do is we can do a lot. We talked about trust in science, but we shouldn't forget science gave us the vaccines. Science gave us the treatment. Science actually was behind a lot of the contact tracing apps. Of course, there were gaps in the science, but that doesn't mean science is at fault. Not the misunderstandings, but the different views about social distancing, lockdowns, masks is not a fault of science. It's a fault of a lack of science, a lack of understanding about the effectiveness of these things. And we haven't generated the evidence we need to do. And so I think there is some distrust in science, but I think overall probably trust in science is pretty strong now if you keep reminding people of these facts. Perhaps trust in politics may not have done so well. Academic excellence has really, turned around the pandemic in many ways. We saw that in many areas, but also academic mediocrity was harmful. We only have to look, my area is therapeutics. We only have to look at the continuing legacy of the arguments about hydroxychloroquine or ivermectin, anti-vaxxers. A lot of that is based on poor science and poor interpretation of science. And so we really have to make sure that we push forward that science is critical to society, and good science is critical, because bad science can be harmful. And we could do a lot, but we can also do more than we thought, and we can do better than we imagined. If you look at the speed at which the vaccines were developed and rolled out, it was unprecedented. If you look at the speed of the therapeutic trials, which I was involved in, it was unprecedented. We enrolled the first patient within 9 days of having written the protocol. It normally takes 18 months. The contact tracing apps were developed in months. We just did things a lot quicker. We did things much cheaper. The average cost of a patient in our trial in recovery was about £500. For a pharmaceutical trial, it's about £35,000. So we enrolled patients within 9 days. We had our first answer within 90 days. We had 3 answers in 100 days at a fraction of the cost of pharmaceutical trials. And the vaccines, you saw the rollout of vaccines at massive scale, not for profit, with facilities like COVAX, which made a huge difference. So we can do things better and have a bigger impact. And I think that's the lesson is, if we can do that, why can't we do it every day? We need to understand what allowed us to do that. Now, sure, some of it is the unusual circumstances of the pandemic, but there's a lot of things that we learned that we should take forward. We can learn how to do things differently from what we did do, but I think there are some things that we could do better. We were very responsive, but we could have been better prepared. We could have had, vaccines at a later stage of development. We could have had drugs at a later stage of development. We could have had contact tracing, social distancing policies better understood. And we certainly could have had better evidence about face masks and other non-pharmaceutical interventions. It's been an issue for a long time. What's the evidence for the value of face masks? And we looked at it in some of the government committees pre-COVID, and we always said the evidence base is very poor. We just don't know. But there was no investment in answering those questions. We need to build on the equity as well. What we saw was that the science impact was not equitably shared. And so we need to make sure that there is investment in equitable sharing of the benefits of science. And we need to work on trust and confidence, because it's not just about people trusting scientists, it's about them trusting the science and believing what the science is telling them, and understanding the uncertainties as well. So how are we going to do that? I think we need to do a few things. We need to consolidate what we've done, and we're trying to do that in the Pandemic Sciences Institute, which is to bake in that interdisciplinarity that was so fantastic and is so important, with basic scientists, with practical interventions, with clinical trialists, with behavioral scientists, social science ethicists, and political scientists, because they're all part of the dynamics of how we respond effectively. We have to, I think, consolidate mentally as well. We have to reset our expectations. We've seen what's possible. Let's not go back to our old expectations. Let's expect that we can do that every day. And I think finally, I would say we need to advocate. We really need to make sure people don't forget. People have really short memories. And those of us that have been involved in epidemics for quite some time, you just see this swinging back and forth, this pendulum between, it's SARS-1, it was tragic. We'd invest hugely in Southeast Asia for about 6 months, and then we'll reallocate all the funding. The same after bird flu, the same after the Ebola outbreak in West Africa. We'll start a new vaccine manufacturing facility in the UK because we don't have vaccine capability. Oh no, we'll sell it off now because we need some money. You can already see that happening now, post-COVID, where it's back to business as usual. And I think we should all be strongly saying, don't forget how bad it was. And it was business as usual that got us into that state in the first place. We need better business. So thank you very much, Thomas.
Thank you, Professor Horby. So in a moment, we're going to move out to the reception, but I'm delighted that we're going to give our last word on the way forward to Professor Sir David Nabarro. David is co-director and chair of global health at Imperial College London's Institute of Global Health Innovation. And in March 2020, he was appointed special envoy of the WHO Director General for COVID-19. David has a long experience on infectious diseases, from his time as a lecturer at London School of Hygiene and Tropical Medicine to an advisor to the UK government, then shifting to the multilateral system in the WHO and for the UN, looking at avian and pandemic influenza, looking at West African Ebola outbreak, looking at a whole range of different global challenges, and also in the environmental space. David has also been a extremely valuable advisor to the project over its 3 years, so we are extremely grateful for his insights and inputs. And there's no one better to give us our final word on how the way forward might look from here. David, welcome. Over to you, please.
Well, thank you very much indeed. First of all, I hope I'm audible. I wish I was there. I'm talking to you from Geneva in Switzerland, which is my base. Special greetings, really, to Tom Hale, and special greetings as well to Dr. Anna Petherick, who's with you, Tom. And I'm just delighted to hear you, Anna, and wonderful panel. Really, really superb. I would concur with others, and very, very good to hear from Peter Horby just now. Lots of important things. So you could say, well, there's nothing left for me to add. The mix is already strong. There's such a lot of respect for what you've managed to do through OxCGRT. Perhaps I should just shut up and let you all go quickly to have the reception that awaits you. And that reception is so important. It's the time of thanking and appreciating this wonderful cadre of volunteers, some of whom have tuned in today. So good that you've done this and continue to do it. but I've got things to say, and I'm going to do it now. First, it's come out from so many of you, and it came out in the panel strongly, but let me say it really clearly. In infectious diseases, it's the pathogen that's the problem, and people are the solution. That means that citizen engagement in everything to do with infectious diseases is absolutely critical. And it's not engaging them just to do what we want them to do, it's engaging them as partners. I've learnt this in so many responses, but particularly in Ebola in West Africa, when a president of a country where somebody had just been shot during a demonstration against a lockdown said, we will not treat the people as though they're our enemies. We will not use live rounds in controlling the population. And I felt really strongly and more than ever before during this panel, how vital it is that all of us continue to say people are at the heart of the solution. And that means informed citizens. It means citizens able to engage. It means citizens that are welcome in the response and that feel fully respected. Second, in all work on outbreaks and pandemics, there are uncertainties to be navigated. How wonderful that Peter is leading a Pandemic Science Institute and he's explained to us exactly why it's there, but also how wonderful that we acknowledge that the role of science is not to be a source of truth. The scientist is not to be considered as a person who has the secret code and is ready to unleash it on everybody. No, science is a way of testing issues and of finding out whether or not they stand up to the test. And a scientist, we're led to believe, is generally quite pleased when the hypothesis turns out to be wrong. That's why we've got this confusion about science. It's that in the media and in certain places where people like to disparage, scientists are often treated as though they are somehow truth tellers, and when they get it wrong, they're somehow incompetent. But let's be clear that actually, because there are so many uncertainties about most infectious disease outbreaks and pandemics, it is absolutely essential to have science there to test out what's going on. And we need to be able to do this, and that's where it's tricky, in ways that keep people together through thick and thin, despite the uncertainties, with vulnerabilities emerging and people caring for each other through those vulnerabilities. And the role of government, which we very much hope will be united through all this, is to support people as they handle these uncertainties, and so on and so forth. Blavatnik School is the right place to be doing this kind of work because it's so important. And actually, that's why OxCGRT has been so vital to all of us. But then within that, there is something very special about government. And the ones that seem to have done so beautifully are the ones that have followed this basic rule: anticipate, communicate, help people make sense, help people adapt, integrate locally. Gosh, we had some good examples today. And if you are going to ask the local people to take the initiative, as we heard in Chandigarh, then make sure that the centre covers them and doesn't throw them to the wolves when things are inconvenient. So all this about manner of governance and role of science in governance is absolutely critical, and it's come out beautifully today. Third, remind everybody a lockdown is what you do when all else does not work. It's a last resort. The World Health Organization said this after the visit to China in February 2020. We kept saying it, and we keep on saying it now. So when people come along to me and say, oh, the World Health Organization got it wrong because it advocated lockdowns and everybody went into lockdown and look at all the damage they did, my response is quite simple. We said, don't use lockdowns as your primary means of controlling. Instead, remember, it's been known for years, and Vietnam community has shown it so well. When you've got an infectious disease, you identify and you isolate quickly. You don't hang around and test. And what really matters is enabling people to isolate and to isolate with comfort. It doesn't work if you pay the people who have to go into isolation about £95 per week when they are earning £450 on the assembly line or in a meat factory. You will get spread. Fourthly, communicate. Meet people where they are, not where you want them to be. Regular, connecting communication, beautifully said by Caroline Edwards. But all the time at the heart of this work, and what OxCGRT has shown, that where the communications are good and touch people, then there's real results. And you do have to change position in this kind of work. You know, a lot of people came into this pandemic using flu-based models to decide what strategies to adopt, and they probably weren't always the right strategies. The position had to change when we realized that those models had to be replaced by those that are specific for coronavirus. Remember, number 5, when there is uncertainty, there will be contest. When there is contest, there will be name calling, and a lot of horrible stuff has happened. But we've just got to accept that public health has changed forever. The license and space within which we can operate has altered. And that's why the communication really has to be of the kind that secures permission from people to take action on behalf of a minority through inconvenience, perhaps to a majority. The secret of public health, and so difficult, especially when that social contract has been affected. And I really loved it, actually, when Anna was saying, she was talking about the social contract in language that I found really very attractive, and making the point that that's the way ahead. So globally, what's going to happen? Last point, the international community is negotiating a new pandemic treaty, new financing mechanisms, new cooperation, and we hope very much that this will take us forward. Thank you for the chance to speak. Sorry for going on too long, and I very, very much wish you all the best for the future. Again, gratitude and appreciation from us here.
David, thank you as always for those inspiring words and for all the work you and your colleagues have done over the past 3 years. It is inspiration to all of us and all of the volunteers. We're going to move out now for a reception just outside. We hope you'll find some refreshment and also a chance to hear a bit more about the project and meet the volunteers at the half-hour mark. Those of you watching at home, have a break and come back at the half-hour mark for a little bit more context. Let me just close by asking everyone in the room who has been a volunteer for the project or who has worked for the project to please stand up. And now will everyone please join me in thanking all of our speakers today and all the people standing in front of you. Thank you all. Hello, everyone. Welcome. I don't mean to interrupt your refreshments for too long, but I did want to say a few words and allow us all to hear a few words from some of our amazing volunteers. I'm going to start by saying a few words about how this all began, and then turn to Toby to talk about the volunteers, turn to Anna to talk about the impact, and end with some thank yous. And please do continue to enjoy the drinks and the food as we're speaking. So if you think back to March 2020, we were here in this room, actually in that room behind me, as I said in the session, having a conversation about the different pandemics policies we were seeing emerge. And some of us thought we should probably organize that information in some way to make a useful product for the world. So we had a first meeting actually in those rooms just over there, where some of you were. And you'll remember it was quite energetic. We didn't know what was happening. It was actually the last day of the term. And that was the last time that many of us were in this building for a very long time. So it was all kind of happening right in the moment. And from that meeting, we had a really good idea. We're going to have a tracker for government policies in response to COVID-19. And we were going to put it into a system of Google Docs, which was our first attempt to build a COVID tracker. And so that was a good start, but clearly not where we wanted to go. And I was very fortunate, or we were all very fortunate, because Sam, my husband, was not working at the time, and so had the ability to create an actual database, not just a set of Google Docs, which was very helpful. And then putting us all together, the project launched on March 22nd, 2020, which was 3 years ago and 2 days from back in time. And since then, we've been continuing to build the airplane as we fly it. And it's been just the most extraordinary journey, because we've been changing the policies, changing what we do as the pandemic has changed and as things have evolved. And it's really been a learning curve for the world and for us. It's been a lot of fun at times. It's been hard in many ways. And it's been something I think very special for everyone who's been involved in it as a volunteer, as a supporter, as a partner, and as someone working on the project. And when people ask me, well, how did you do all of that? How did it all work? How did it come together? What makes it tick? There's really, I think, one really clear answer in my mind, which is a shared purpose. And it's a really sort of obvious thing in some ways, but it's also a rare and fragile and precious thing. And if you think about what makes a tracker work, it is really this community of people united around a shared purpose, trying to be part of something bigger than themselves and to contribute something to the world that's bigger than what they can do individually. And in the last 3 years, to start with, we've seen certainly a lot of examples of the darker sides of human nature and some of the inequities and the huge costs and pain that's come with the global pandemic. We've also seen these points of light of people working together, doing things that are really extraordinary and new and special. And I just feel very privileged and lucky to be part of one of those things. And the heart of it, of course, are all of our amazing volunteers who are here to celebrate tonight. So let me pass to you, Toby, to say a few words about those volunteers and to invite some of them up.
Thanks, Tom. So from that launch in March 2020, as well as scaling the database from a collection of Google Sheets to a SQL database, we also scaled the team quite rapidly. And so, we had a core team of about 10 to 20 staff here at BSG, but really we had hundreds of volunteers, and they were the heartbeat of the project. And so our volunteers showed up every week, week in, week out for 3 years to do this pretty skilled work of searching, interpreting, and contributing data into our data set that then ended up being used by policymakers all around the world. We had volunteers from over 100 countries contributing. And as Tom said, it was really a group of people united by this opportunity to build something impactful and to make a meaningful contribution. And so, as we've heard today, we really all owe a great deal of thanks to those volunteers who, out of generosity and passion, gave their free time to build this amazing resource. And I think we're also very proud of how we've attracted volunteers from many different walks of life. So of course, we had a lot of students. That's where we started here in the school, but we've also had professionals. We've had managerial staff in corporations. We've had healthcare workers contributing data in between shifts. We've even had someone who was on a gap year in a boat in the Pacific Ocean contributing data through a satellite uplink. So we've actually prepared a video which includes 10 of our volunteers from all around the world, kind of talking about their experience contributing to the project, because I think hearing from them is probably going to be much more meaningful than hearing me tell you about their experience. So we'll play that video now. I think we'll play that video now. Do we have the video? If we...
Hi, my name is Victoria and I'm from Porto Alegre in the south.
If we don't have the video, and I'll give it a moment, but if we don't have the video, after the video, and so I'll invite them up now. Shoaib and Caitlin, two volunteers that are here with us this evening, we're going to kind of share a bit about their motivations for joining the project and their highlights in being in the project. So maybe Shoaib and Caitlin, we might, if it's okay, flip things around while we wait for the video. So if you could come up now and we'll hear from you and then see if we've got the video.
Yeah, there is a technical issue, so
let's postpone the video. So Shoaib, could you come up as well? And so Shoaib and Caitlin are two of our volunteers, two of our longest serving volunteers as well. So I think Shoaib joined the project in the middle of 2020, which was actually, you know, the height of the pandemic, and that's been about 3 years of service and contribution. And Caitlin joined not too long after, I think at about the beginning of 2021. So Shoaib, I might ask you if you could just share sort of what motivated you to join the project. And then Caitlin, it would be great to hear from you some of what you've gotten out of being involved with the project. So Shoaib, I'll pass over to you.
Sure, thank you. While walking through the William Shakespeare Sheldon Theatre this morning, I was meeting with few of my friends. I came to know an interesting dissimilarity, rather outrageous dissimilarity between the pandemic and the Romeo and Juliet. One is caused by the coronavirus, other is by Veronica virus. Veronica. So anyway, so it's a rather serious issue. So it was an unfortunate event when I started working on this. So even at the outset of beginning, I was not sure about what is this all works about it. So, but unfortunate case, I was myself suffered the COVID and recovered, but my father couldn't, so he lost his life. And I'm sure all of us lost their loved ones, the people they know, their friends, their enemies perhaps. But so since the outset of the project, I was very interested in this. And as Toby mentioned, in the middle of 2020, I started working on this. And since then, me and all of the volunteers across the world were keen observer of the policies, not only on their local jurisdictions, states, regions, countries, but across the world. I came to know about the functioning of small islands to the big continents and the big countries like India I belong to. So it was a wonderful journey so far, and I'd like to express deep gratitude to the entire team, Professor Hale, especially Toby, Dr. Anna, and Adam, to pull this incredible project so far. And yes, thank you, everyone.
So hello, everyone. I just wanted to share a few insights from my time. I was reflecting on my journey and what has changed for me. I think the first thing I'll mention is that I believe I've become a better researcher for having been a part of this project. And the thing that really pushed me was all of you, to be honest, that my fellow volunteers. I wanted to be as good as, I wanted to be as informative, as diligent week after week to mitigating success. I think that was really my first push. And then on the flip side, being able to see in real time the data being used in publications, in research, in UK cabinet meetings, it really validated those late nights in which I was trying to research a country I've never been to or a language I don't really understand, but wanting to understand it enough to be helpful. So that was really important to me. And then on a personal note, I feel that it really connected me to something larger. So from my sitting in my bedroom in lockdown in Germany, connecting me to something larger, taking my anxiety and just confusion about COVID policies and connecting to the bigger picture outside of my room, outside of this place, and taking that anxiety and making it be something a bit more intentional, a bit more quantitative, a bit more understandable, a bit larger than myself. So I've really appreciated that, and I appreciate all of you. And I've been very grateful to be a part of the project, and I'm grateful to be here today. So thank you.
Thank you, Caitlin and Shoaib. And I think now we have the video ready to go. So let's hear from 10 of our other volunteers around the world.
Hi, my name is Vitória and I'm from Porto Alegre in the south of Brazil.
Hello everyone, I'm Suziu from Shanghai, China.
Kia ora, I'm Woman Jeka. My name is Ashley Shipton and I am a New Zealander living in Australia.
Hi friends, my name is Yasmin Hamzi. I'm from Egypt.
I am Okore Chinagrom Bonaya. I am from Nigeria.
I'm Nada and I'm from Canberra, Australia.
I'm Windsor and I'm living in Beijing, China.
Hello, from Toronto, Canada. I'm Adil Saeed.
My name is Lucas Almendra. I'm from Mogi das Cruzes, a city in the state of São Paulo, Brazil.
I chose to volunteer with OxCGRT because I am currently a paediatric doctor doing my PhD in the effects of COVID-19 policies on maternal and child health outcomes in Victoria, Australia.
I was interested in public policy and deeply affected by the epidemic control measure as a travel person. I found OxCGRT a reliable and organized project for me to commence my study in health and public policy field.
The motivation for joining the OxCGRT COVID-19 Governance OxCGRT team was the belief that this project outcome will archive the governmental response to one of the critical transformations in contemporary history.
What really made me to join this program is the pain caused by COVID-19. So that was why I joined this program. And the fact I'm also passionate about research.
At the time, Brazil was facing a huge, great wave of misinformation. And I felt that it was my duty to fight misinformation. That there's not a better way to fight it than with science.
I joined Team Canada in November 2020 after reading a New York Times article about COVID policies in the US. Little did I know that I would still be tidying up codes as a Team Canada volunteer now, more than 2 years later.
It's given me the chance to work with other students and academics in a really supportive environment. And I've been able to gain some valuable insights into the ups and downs of big data collection programs, as well as pandemic policy itself.
What I enjoyed the most about being a part of this program was that I was able to meet other coders and share this experience with other researchers from Brazil and from around the world.
If you ask me what have I enjoyed about being with OxCGRT, I would definitely say is the weekly meetings of the Chinese international team, where coders and viewers would talk about the difficulties they've met when collecting data.
This unique personal scientific experience is an embodiment of Walt Disney quote, "If you can dream it, you can do it."
In OxCGRT, I came to realize that not only myself, but all the coders and reviewers are important parts of a project. We who care can really make a difference.
And to know that through this weekly global teamwork, together we are creating an extremely beneficial resource for policymakers, for health professionals and communities on an international scale. So that's been pretty cool.
So I think just to briefly wrap up my bit about the volunteer experience and what the volunteers contributed, I think, you know, on paper or maybe day by day, the volunteers' task was a task of data collection, data entry, textual analysis, but really the volunteer experience was, as we've heard, something much more than that. I think the volunteers and the people that have contributed to this project are a group of people united by that passion and that desire to make a contribution during one of the biggest crises any of us have ever witnessed. And so with that segue, I'll pass over to Anna to talk a little bit about the contribution and the impact of the project. Thanks, Anna.
So how to talk a little bit about the impact. So one of Tom's favorite phrases, which I have teased him about a number of times, is that we are building the airplane as we fly it. And that is true. Has been true throughout the project, but I think we can now say that we're landing the airplane somewhere more beautiful, definitely somewhere a lot further away, and somewhere higher than we could possibly have dreamed. So to the volunteers, you have contributed so much that I cannot summarize in a few minutes. First of all, of course, your data has fed into policy making around the world. To give a glimpse of this, there's all the reports, but to meet people high up in government who speak the language of our code book, who talk in C7s and C8s, it's bonkers, the impact that you've had. And to pick up on something that Lucas, a volunteer from Brazil, said, you know, I think one of the unstated impacts is this pandemic occurred at a time when there were a lot of leaders questioning science around the world, questioning big government. And what this project has done is really move the conversation on, push it forward beyond what is happening, because we gave the world the data on that, to what works. So thank you for that. The second, of course, is on citizens and empowerment. You guys made a data set that wasn't only freely available, but super easy to use, which meant that, you know, 14-year-olds could download it and you know, hold their local council people to account. And I heard stories about that. And of course, the media everywhere could use it. And that was a wonderful thing for the world. And academics, well, I think the main thing academics did, honestly, was to crunch numbers and tell the policy makers what was the best evidence. Most academic projects count impacts in terms of citations. This project, as Rafa has done, can count our impact in terms of how much we affect the impact factor of Nature journals. And it's not a small number. And that's only our direct impact by our papers, not the people using our data. So that's the stuff we can see and measure, but there's a lot of other stuff. The main one, of course, is all that evidence-based policy making to the extent that leaders have chosen to do it, but all that you made possible has helped people in very tangible ways, in ways that we'll never see, we'll probably never know about. But there'll be lots of people who had better health outcomes than the counterfactual of this project not existing. So thank you all immeasurably, as that last point made clear. Thank you all so, so much.
Right, so the best way to thank people, of course, is letting them get back to drinks and refreshment, which is what we're going to do momentarily, but we have to stop first to acknowledge a few other contributors who have made this project what it is today. And I want to start with our amazing advisory board who came together in the first days of the project. David Nabarro, who you've just heard from, is one of the members, but there's a number of others of you here, and you really helped shape our thinking, often in challenging ways, but in ways that made us much stronger. So thank you, advisory board members. Thank you also to the many, many partners and collaborators who included the UK Cabinet Office, the UN Office for the Coordination of Humanitarian Affairs, the World Bank, Pandemic Sciences Institute here at Oxford, and other colleagues around the university, the many academic partners around the world, in Brazil, in China, in the US, in Senegal, and other places. Thank you as well to Our World in Data, our partners here in Oxford, who have done a huge amount to visualize and communicate data from our project, but also many other sources to the world. Thank you, Microsoft, for giving us the infrastructure, data infrastructure to power this thing. Thank you to the International Public Policy Observatory for your collaboration as well. Partners are great, people are great, and all of them need money to run. So thank you to those who have provided some of the funds to this project. They include the Blavatnik Foundation, Roche, the Economic and Social Research Council, the Gates Foundation, the New Venture Fund, and Pax Sapiens. We really couldn't have done that without the support. The project was born without a single dollar, cent, dime, pound, yen to its name, and quickly realized we needed a few of those at least to make an impact. So thank you to you. Thank you to the Blavatnik School, to all of the colleagues here in this building, from the comms team, to the finance team, the HR team, the events team, especially for tonight, and for everyone else who made it work. Thank you to Dean Nari Woods for your infatigable leadership and support, and cheerleader #1 for our work, which we really, really appreciate. There are a lot of people who have worked on this project. We've been around for 36 months, and we have had 37 people work on the project in that time span. So more than one a month. And you're too many to name, but I'm going to do it anyway because you deserve recognition. So please hold your applause to the end. But thank you, Katie Amir, Jessica Ananya, Bernardo Andretti, Noam Angrist, Roy Barnes, Thomas Bobby, Emily Cameron Blake, Alice Cavalieri, Martina Di Falco, Lucy Dixon, Jody Elms, Rodrigo First, Raphael Goldsmith, Caitlin Green, Laura Hallis, Pia Kira, Sandy Lapping, Mariana Luciano, Saptarsha Majumdar, Radhika Nagesh, Tejas Oliveira, Anna Petherick, Toby Phillips, Annalena Pott, Luya Wren, Liz Ribera, Julia Sampaio, Helen Tatlow, Will Tornes, Andrea Vaccaro, Adam Wade, Sam Webster, Claire Wenham, Andrew Wood, Hao Jia, and Yushi Zhang. The 36 of you, and me, 37, is a great team, and it's been such a pleasure to work with all of you. So last word, and the one I think that really sticks with us is before you eat, drink, and be merry, and we hope you have a great celebration tonight. Everyone who contributed to this project has something really special that no one can ever take away from them that will last the rest of your lifetime, which is that during this huge crisis, you, volunteers, team members, funders, project partners, etc., contributed something that really made a difference. And that's unique and special, and something we need to do more of in the future, as we heard about today, but something that I'm really confident that we're going to do more of because I've seen it can work. And we've all seen it can work, and that is a spark that's going to be very valuable for us in the years to come. So thank you all, and enjoy the rest of your evening.
And there's probably one last person to thank. Thank you, Tom, for your leadership and for setting up this project in a pop seminar in March 2020 and letting us all come along for the ride. I think it's been incredibly generous and open in how you've built this project, and it's created a wonderful thing for us all to jump on board with.
Yeah, this project would not exist without Professor Hale. Not only for the brilliant idea to begin with, but there have been so many difficult decisions to guide this over the 3 years. And he has been a genius at managing it. And he's been lovely throughout. So thank you, Tom.